A very good afternoon to you, and welcome to the post-lunch session of glaucoma. I am Richa, and I'll be talking on a very simple way to evaluate the optic nerve head pertaining to glaucoma especially. So evaluation of the ONH is very, very central to the diagnosis of glaucoma. And the aim of any kind of ONH evaluation should include the diagnosis, as in you should be able to diagnose whether the nerve that you're seeing is normal or abnormal, quantify the damage that has happened, and analyze what is the next step. In our practical OPD, we have a very limited time, hardly 10 to 15 seconds, where you actually have to glance at an optic nerve, and you should have some key features on which you actually focus, and then you strategize the further action. So let us look at this optic nerve. Whenever we are looking at an ONH, the first and foremost thing that we should be able to do is we should be able to delineate the scleral ring. Look at the upper margin, look at the lower margin, and here we have the disc diameter, right? And in a similar way, delineate the cup, look at the cup edge, the superior border, the inferior border, and you have the cup diameter. And so now we have got the CD ratio, and the area between the two margins is nothing but the neuroretinal rim. That's the basic of ONH evaluation, right? So let us look at few of the changes that may happen in glaucoma. I've divided the changes into two parts, intra and peripapillary changes. The first one is the optic disc size and shape. Why is it important to actually look at the size of the disc? That's because a small disc will have all the axons compacted together. Any focal damage will lead to higher, loss of the axons. So here we have two pictures here. If I asked you the CD ratio in both the pictures, both of them are roughly 0.55, but then the right one is a normal disc. It's a large disc. The left one has a focal notch inferiorly with a corresponding NFL defect, and that's an abnormal disc, right? And how do we actually calculate it? Look at the graticule mark at your slit lamp and multiply it with the correction factor with respect to the lens that you're using. Now, I've talked about the scleral rim, the importance of that. At one glance, we'll say that it's a very large disc with hardly any cup there. But then again, look carefully, that's nothing but a myopic disc. So the scleral ring is actually very small. In few of the patients, it's not always possible to actually delineate the scleral ring. This is a 13-year-old female with a counting fingers half-meter vision, and this was a unilateral involvement of the disc. So this actually was morning glory syndrome. Similarly, a patient of 45 years with a bad vision, and this was a disc coloboma. There was also an intercalary membrane which was picked up on B-scan. Coming to the neuroretinal rim, so it's nothing but the area which is actually occupied by the retinal nerve fiber axons. So it's important for you to look for two things. First is the pattern of the thickness and any area of focal thinness. This is the isn't rule, which says that inferior rim is more than superior, more than nasal, and then temporal. So we may have focal notching or thinning, which is present in all these three discs. Okay. This is a case of a 49-year-old female, a case of open-angle glaucoma. So again, if I ask you, you will tell me that the left eye definitely looks abnormal. The right one looks okay, yeah? But then if you look carefully, even the right one has a NRR slope with a corresponding field defect. Left eye definitely has a gross NRR defect. So this again is an 18-year-old male. If I ask you what is the CD ratio, you might say right eye is okay, 0.1 to 2. This looks cupped. So, but is it really cupped? It's not cupped. It was a case actually of traumatic optic neuropathy. This is actually a pallor, disc pallor, no cupping. So again, what is abnormal if I ask you? The right eye, CDR is around 0.55, left eye is around 0.45. You might say that the right disc is abnormal, but then we sort of limit ourselves with glaucoma. There's nothing wrong with either of the discs. it is this. This is actually a case of CSCR. So don't limit yourself to one thing, you know. Look at the eye as a whole. So we may have overpassing of circumlinear vessel. There may be lamina dot sign, which is nothing but exposure of lamina cribrosa seen here. Coming to the cup configuration and the CD ratio. So again, cup is nothing but excavation in the optic nerve head, and it can be delineated by a sharper edge, a vessel bend. Again, CD ratio, we have already discussed about it. The right eye, if I ask you, it's around 0.15 to 2. Left eye definitely looks around 0.9. Also peep inside the cup. So this was a very interesting case, a case of status post VR surgery, post SOR. So there was a small silicone oil bubble which was seen there. The CDR looked okay, but then eventually, you know, the CDR actually kept increasing. So always peep inside the cup also. Coming to the peripapillary changes, we may have optic disc hemorrhage, so it may precede an optic disc change or a field loss. If it's a new patient, it may precede the changes. If it's an old patient, you may need to reassess the target pressure. So many a times it's very small. You actually have to actively look for the trans hemorrhages. Nerve fiber defects may be localized, may be broad, wedge shaped like this, or may be diffuse like this. Okay, so this was a case of a 30-year-old male. Pressures were 12, vision was absolutely okay, but he has been on steroids on and off since many years. There was a PSC both eyes, and this is how it looked. A very diffuse sort of RNFL defect. This was the OCT scan. 44-year-old male, primary open-angle glaucoma. Again, there was also an hole-in-horse plaque here. You can actually visualize the defects very nicely. Diameter of retinal arteriole. So you might find focal arteriolar attenuation in cases of glaucoma. So here it is associated with this nerve fiber defect. And can you really spot the difference? You know, there's actually a gross difference. This has a diffuse arteriolar attenuation. And the last one is peripapillary chorioretinal atrophy. You have the central beta zone and peripheral alpha zone. So in non-glaucomatous eyes, PPA is most commonly seen temporally. If there is a significant optic nerve cupping, you might see a 360-degree PPA also. Again, this was a case of a 45-year-old male with PSC, right eye, and PSCG in the left eye. Just look at the peripapillary atrophy, which is seen here. More advanced here, which is maybe associated with the cupping also. So this is what I was talking about, the 360 degrees PPA. 32-year-old female came to the clinics with complaints of scotomas. If you actually look at the disc, these look absolutely normal. But this was what we found on the fields. The patient was actually operated for pituitary adenoma. So again, always correlate everything. You know, the history, the findings, the examination, everything. That's all. Thank you so much.
Thank you, Dr. Richa, for the wonderful presentation. Now I would ask Dr. Shivam Gupta to please continue with this presentation. Next, Dr. K. Subhasini.
A very good afternoon to all. Thank you, AIOCMT Scientific Committee, for giving me the opportunity to talk on the topic of ABCD of glaucoma diagnosis, in which we will be discussing a step-by-step guide for mastering the art of glaucoma diagnosis. So yes, we start with the A, which is a thorough history exam, then a slit lamp by microscopy, correct IFP measurement, detailed gonioscopy, evaluation of optic nerve head. Thank you to madam, we have almost covered the topic, and fields and relevant investigations. So what is the importance of history? It is the first step of doctor-patient interaction, and it's the aim to win the confidence of the patient, and we will develop a rapport. So we should know about the patient's age, the ethnicity, the location where it comes from. Then we have to ask the duration and severity, and what are the symptoms of blurred vision, eye pain, colored halos, field of vision. But yes, we cannot forget the fact that primary open-angle glaucoma is a silent thief of vision. Ask the past ocular history of what is the refractive correction of the patient, whether he had any trauma, any laser procedures were done, any surgery was done. Along with that, we have to ask if the patient is using a chronic, like long-term steroid use, or any known documented allergies there. Systemic features, which can cause glaucoma, and we have to ask. Some patients' lifestyle changes, like some people have a habit of having a lot of water in the early morning, and some yoga posture like Sirsasanas have known to cause raised IOP. Along with that, we have to ask about the socioeconomic history of the patient. Some occupations like trumpet blowers are known to have increased IOP. Along with that, family history of glaucoma has caused a 10% increased risk of glaucoma. And here we have done a study in our institute which shows 6 generations of patients having juvenile open glaucoma and documented mutation in N480 mutation. Examination should start with general examination, and systemic and ocular correlation has to be done. Like here you can see a child with phacomatous pigmenta vascularis, another with neurofibromatosis. Going on to facial examination, in Indian population, we can easily miss this port wine stain on a sturgeon patient. Along with that, oculomelanosis nevi can also be missed. So a detailed slit-lamp examination should be done. Along with that, we have to find the clues for a raised glaucoma, like dilated episcleral vessels, Harb's or post-vitreoretinal surgery, or other signs of post-surgeries has to be documented. Van Harris grading is important, but yes, don't miss gonioscopy. Gonioscopy is must. Glaucoma screening, yes, a simple torchlight test that can give a clue of glaucoma, even if you are campsite or peripheries, is a RAPD, which has to be done. Look for ultimately for the signs of AGM allergy. Look, and then starts with the tonometry. As you know, there are many tonometers, different classification. You should know tonometer, but yes, we have to go ahead with applanation tonometer. So here I'll start discussing the steps for measuring using applanation tonometer. Ensure the weekly calibration has been done. It should be done by you. Make sure you're not asking your technician to do it, because high chance of missing the readings. Explain the procedure to the patient, because patient may have anxiety and may squeeze the eye. Sterilize the tip before and after the procedure. Then complete the setup, bring the tension knob to 1. Don't make it at 0, because that will cause abrasion and because of hysteresis. Then use the cobalt filter, enlarge the full, dim the room lights, and go ahead. Make sure you have approximately 60 degrees between the microscope and the illumination source. The end point is the meeting of the inner semicircles, and multiply by 10. That will give you the reading. But yes, be well aware of the factors which can overestimate or underestimate your changes, like thick cornea, thin corneas, astigmatism, and accordingly we have to modify. Then coming on to gonioscopy, it is very essential for guide of diagnosis, formulate a treatment plan, and planning ahead for intraoperative images. So you should know the gonio lens which you're having and what you're going to see, whether you're using a Goldman, Zeiss step, and the importance and benefits of, and the case by selection for it. Check for the surface of the gonio lens every day, I must say. Explain the patient procedure, make him comfortable, put adequate topical anesthesia, practice correct placement of the lens, ask the patient to look up, gently place the lens, and go ahead. First look at the superior, then the inferior, then turn around 90 degrees, then you can use in the lateral side. Practice placement of the lens very gently. You have to place to avoid any corneal folds. Then centration has to be checked. It should be in primary position, and a good way to look for any decentration is the appearance of an air bubble that proves that the area, that portion the lens had decentered. Then along with that, make the external wedge, then accordingly grade your angles and describe the angle structures which you are seeing. Then describe according to whatever grading system you're using, a clear indication of how open the angle should be there in primary position. Insertion, iris insertion and angulation, the amount of pigmentation, any peripheral anti-synucleus, neovascularization, and other structures. Then ONH evaluation, we go ahead with a 7-step, as madam described, from size, then shape, then cup disc or the rim disc ratio, then the rim shape, any notching was there or not, RNFLD, whether it's a localized or diffuse, disc hemorrhages, and any peripheral atrophy. Then order relevant investigation. What I believe the must investigations are pachymetry, HFA, OCT, GCC, RNFL, and fundus photo. And not limiting to that, we have to do a progression analysis of all these 3 to clearly cut what we are dealing with. And then we can do a case-based analysis of ASOCT or UBM. Pachymetry plays a very important role. Then we have to know what is the central corneal thickness we are dealing with. As you can see, the percentage changes, percentage of propensity of having glaucoma in an ocular hypertension patient can be changed according to how thick how thin the cornea is. And these are some scales present to correct it. always correlate your investigational findings from what you have seen in the examination. So here is my ABCD of the glaucoma examination. A proper systemic and ocular history taking and stepwise examination give utmost importance to tonometry, and gonoscopy is the key to glaucoma diagnosis. To summarize, eventually all the pieces should fall in the place. I'm always thankful to the place where I learned ABCD of my glaucoma. Thank you all for patient listeners. Welcome to my hometown for your year's midterm. Thank you.
Thank you. Thank you, Dr. Shivam, for wonderfully explaining all the basic points and the multiple factors which helps us to make the diagnosis of glaucoma. Very nice. Now I would request Dr. K. Subhasini to go with her presentation.
Yeah. Good afternoon, everyone. So the topic of my presentation is ocular hypertension, the way forward. Ocular hypertension is defined as intraocular pressure more than 2 standard deviations from the mean of a normal adult population with normal visual fields and no evidence of glaucomatous optic disc changes. So, but studies differ in their definitions of what is normal visual fields and normal optic disc structure. The management of OHT, we all should understand that it's not simple, because ultimately it's only a subset of patients who will develop visual field abnormalities. The average monthly cost of glaucoma medication, the risks of adverse effects with therapy, the inconvenience of topical medications, and the incidence of non-compliance, these are enough justification not to treat OHT indiscriminately. So we need to have a thorough understanding of the evidence-based risk factors. Which are the risk factors which play a role in decision whether or not to treat a patient with OHT? How do you synthesize a patient's risk factor profile into a recommendation for treatment? And does delaying the treatment of OHT matter? So these questions were answered by the OATS trial, one of the landmark multicentric trials, and it was conducted in 3 phases. The OATS 1 phase was just a proof of concept. This was to identify whether early treatment reduces the risk of conversion of OHT to POAG. And in OHT 2, it was to determine when treatment should be initiated. And the OATS 3 was to determine the incidence and severity of POAG in the cohort and to develop a 20-year prediction model. The results of the OATS 1 study has clearly shown that topical medications reduce the progression of OHT to POAG from 9.5% in untreated subjects to 4.4% in the treated subjects over a period of 5 years. And they also identified 5 important risk factors like increased age, high baseline intraocular pressure, high vertical cup disc ratio, greater PSD, and thinner CCT. In the OATS 2 study, actually in the OATS 1 was conducted over a period of 7.5 years with a treated arm and untreated arm. And after 7.5 years, the phase 2 OATS study was conducted where the treated patients were continued on treatment and the patients in the untreated arm were started on treatment. So, it was found that POAG development after 13 years was 0.22 in the untreated cohort compared to 0.16 in the treated, in the treated cohort. And the absolute effect was greatest for the high-risk OHT. And in the study, we all know that CCT was a very strong predictive factor. A CCT less than 555 microns had a 3.4 greater risk of progression to POAG. But how does this translate to the Indian scenario where in the Indian population the average corneal CCT is, ranges between 520 to 540 microns. And there's another statistic that is used in these studies, and especially in the OATS, it's really makes sense. So that's the number needed to treat. So the number needed to treat was, calculations show that for every patient that is prevented from developing glaucoma, 20 patients with OHT will have to be treated. And this number, Cass and colleagues had stratified based on this, based on the risk profile. And in low risk OHT, this number needed to treat was 98. In moderate risk, it was 16. And in the high risk, the NNT was 7. There's another study, European Glaucoma Prevention Study, EGPS, which was conducted around the same time as OATS 1, and this also showed similar results. So where do we start? So the risk calculators is a good starting point. So this actually gives the 5-year likelihood of conversion of OHT to glaucoma based on the 5 important risk factors. And this gives a 5-year risk of developing POEG. If it is more than 35%, then you can treat the patient. This calculator has reasonable accuracy in distinguishing high and low risk OHT profile. But a word of caution, this risk calculator will be more accurate in patients who resemble the participants of OATS. This is the risk calculator, the scoring tool for assessing risk 2. This is a handheld calculator where you put in all the information of the patient, and then you get the probability of conversion over the next 5 years. And if this exceeds 35%, then you can start the patient on treatment. So if this is not available, then the online calculator is there, so based on which you can calculate the risk. A very important drawback of the OATS study is some of the important risk factors which we all know, like myopia, race, cardiovascular disease, family history of glaucoma, diabetes, which have high risk for developing glaucoma. These were not found to be risk factors in the OATS trial, and especially diabetes, it showed very inconclusive, there was no definitive answer. So there were other studies which were conducted, especially there were cost effectiveness model studies from the United Kingdom and the Netherlands, and they actually incorporated even SLT as a treatment modality in OATS for ocular hypertension. So where do we now move? So the way forward, what is it? So the approach to management should be based on whether they are high risk, moderate risk, or low risk. If the intraocular pressure is more than 30 millimeter mercury, then you need to treat the patient, whether, regardless of whether the cup disc ratio is less or CCT is more. So if the IOP is more than 30, you have to treat. If the IOP is about, it's 26 or more, and the CCT is less, or if the cup disc ratio is 0.4 and CCT is less with RNFL and PPA changes, there again, treatment is offered. In moderate risk, that is between 24 to 29 mm mercury without NFL defects, or between 22 to 25 or more with CCT less than, with thin CCT, or 0.4 or more and CCT is thicker, and with history of family, a positive family history or high myopia, there you can consider not to treat the patient but monitor them. And if you see progression, then you can treat. In low risk group, when the pressure ranges between it's above borderline 22 to 23 and CCT is normal or high, or just 0.4 cup, in those cases no treatment is given, and you just have to monitor once in 2 years. The target IOP, when we decide on treatment, a reasonable aim is to have a 20% reduction. So when considering treatment, clinicians must weigh the known risk factors, the life expectancy of the patient, the quality of life issues, and the patient's desire for therapy. So ultimately, the decision whether to initiate treatment or not for a patient with OHT is the patient's. The patient has to decide. So we need to have more pragmatic RCTs and cost effectiveness studies to understand the to have better data and to decide on the management of OHT. Thank you.
Thank you very much, Suhasini madam, for giving an in-depth understanding of ocular hypertension.
I would like to give non-subject comment on this thing. Please use bigger fonts on your slides.
Okay.
Go on more slides, because see, the people like me to read from here to that distance, and the people, see, this might, I don't know how much year you are in practice, but after a few years you will be having a full hall A and B, and from the last row, it will be very difficult for the people to read your slides. So bigger fonts, and lower margin should be without any fonts, according to my observation. So your font should be as high as possible. So from very long distance, doctor should be able to read it. Otherwise, okay, fine.
Thank you, thank you.
Thank you, ma'am. In between, if anybody wants to ask any questions, you can please, or we will go to the next presentation. Anybody having any questions for any presenter? Okay, then we will take the questions in the end. Now, I would request Dr. Tanushri Hengde, ma'am, to please present the presentation.
Thank you, sir. A very good afternoon, esteemed chair and esteemed audience. My topic for today is decoding patients' perspectives and preferences in glaucoma. You may think, why this so not so run-of-the-mill topic? Actually, we are dealing with a disease which is the second leading cause of blindness only next to cataract, which is irreversible but yet preventable. And the treatment mostly depends on the effective IOP control. There are advances in diagnostics and therapy, but still the prevalence is rising, and along with it, the economic and the social global burden as well. See, having the possibilities of detecting and treating the disease is just one part of the problem, and the other part is the behavior of the patient. This is mainly because glaucoma is an asymptomatic disease, where more than 50% of glaucoma remain undiagnosed. What happens in an asymptomatic disease is the patient's behavior is influenced by the patient's perceived susceptibility to the disease, perceived severity of the disease, perceived benefits of the treatment, and perceived barriers to the behavior change. Perceived is the word here. So a lot of patients don't readily have apparent symptoms, making it hard to convince them that they have a vision-threatening problem. Secondly, glaucoma is a chronic disease which requires lifelong monitoring and treatment. Adherence remains a major problem, more so in glaucoma, where the non-compliance range is from 23 to 60%. So here the understanding the needs and concerns of the glaucoma patient comes in, which can give us favorable outcomes if we strategize accordingly. Look at this study by Newman Casey, who looked into the most common barriers to glaucoma medication adherence. So the listed causes are skepticism about glaucoma-related vision loss, skepticism about medication effectiveness, poor glaucoma knowledge, poor self-efficacy, mistrust of the physician, difficulty administering drops, cause, side effects, forgetfulness, and so on. There's also a study done by Friedman et al., which looked into glaucoma adherence and persistence. So there is a patient's perspectives and a doctor perspective. You see the patient perspective, again the cost, forgetfulness, fear or denial, lack of understanding, and the doctor's perspective, lack of patient motivation to use drops, lack of patient understanding about the glaucoma, inability to communicate why compliance is important, and limited time spent. Just glance over the points highlighted in blue in this slide and also over the previous slide. What is glaring is the patient-provider communication gap. There is a gap in understanding of the disease, understanding of the treatment, benefits and risks. Also, poor understanding of the proper use of medication. Take, for example, the visual field defects in glaucoma. The conventional way of understanding and communicating to the patient is the patient sees blind spots or black spots in his field of vision, which will finally coalesce and cause blindness. But is this what the glaucoma patients see? This study by Crab on a view on glaucoma, you see out of the 50 participants, most of them saw blurred parts and 26 were unaware of their symptoms. None of the patients saw black parts or a black tunnel. The most common symptoms we often come across are missing letters or stumbling over the stairs or they're bumping into someone, etc. So the clinical diagnosis of vision loss may not be reflected in the visual fields and vice versa. Field loss may be invisible to the patient. Also, even when the parametric indices like mean deviation are comparable, you see charts of 7 people here with a mean deviation of 5 decibels, but the functional disability for the patient will vary with the spatial distribution as well as the depth of the visual field scotoma. So a lot of information is lost when we only consider the visual field indices. What I mean to infer by this is giving better visual information about the true symptoms to the patient may help the patient understand that he or she is really losing vision despite not being aware of that. This is one example of the image, what I mean to convey, so which will in turn improve the compliance. Coming to compliance, we just not want the patient to be compliant, like taking medication, but also adherent, taking proper dosages as prescribed, and also persistent. But the burden of using medications day in and out for a disease which patients don't believe they have, cannot feel or self-monitor the consequence of progression is not many of us are giving a thought. There is a lot of deal about using eye drops regularly. Also, administering eye drops is not easy. Most of our patients are old and more than 10% miss the eye completely, maybe of the dexterity problems or inadequate vision. Also, the side effects of medications play a major role. Glaucoma as such, which is asymptomatic for the patient will become symptomatic because of the side effects of the drops. Cost, including direct and indirect cost, is not which many of us give a thought. I will not dwell into details. I think the next speaker will be covering on these aspects. So what is important is we should understand the impact of glaucoma on quality of life, the psychological toll, like diagnosing a blinding condition which can cause significant anxiety, fear, depression, visual repercussions, side effects of the treatment, and also the financial burden. Are we seeing it clearly? We are often used to claiming the success of glaucoma management with parameters like IOP, visual fields, and damage progression. But from the perspective of the patient, the other concerns may be far more important. Understanding this will help us to strategize the treatment more individually and improving the adherence. After all, the goal of glaucoma treatment is to maintain patients' visual function and related quality of life at a sustainable cost. So, are we doing enough? Let's bite the bullet. No. Look at this study which showed major of the doctors are either reactive or skeptical. They are least likely to detect and address the non-adherence proactively, or least likely to discuss glaucoma or the importance of treatment with the patient when initiating treatment. Final thoughts. By its nature, glaucoma is a perfect setup for patient non-compliance, be it diagnosis, medication, follow-up care, treatment delay, or refusal. And the consequences, unfortunately, are not felt immediately, but are delayed by as long as several years. So, a proper communication with the patient and his family. The first and the foremost time is the time of diagnosis. Just not tell the patient, ask for the problems, provide information, assess their views on treatment. Treating adequately to minimize progression. Target IOP is also about quality of life of the patient, be it by simplifying the medication regimens, teaching proper drop application, tailoring it to patient's lifestyle, preferences, preservative-free and drops. Of course, there are advances in treatment which are opening up new avenues in management of glaucoma care, but right now medical management is still the cornerstone and adherence is the main issue. And let's not forget, let's prioritize the patient and not the disease. Thank you.
Thank you, Dr. Tanushree. One question I would like to ask, what is the most important thing which we should do while treating the patient actually for patient compliance?
First thing is actually conveying it to the patient about the seriousness of the problem.
Right.
That is a major barrier what we are having right now. Once the patient is convinced, then the next of the steps become easy.
Yeah, and what I would suggest is that after confirming or diagnosing the glaucoma, just spend few minutes more with the patient. Give him proper understanding of the disease. Tell him about all the consequences and tell him what will be the side effects of the medicines also. That is also very important because a patient will have to use the drops for lifetime. And so he will have to face lot of things. So it is very important point which she pointed out. Very nice presentation. Thank you, Dr. Tanushree.
Thank you, sir.
Sir, you would like to add something?
No. Anyone of glaucoma specialist have the experience of TUG, therapeutic ultrasound for glaucoma? Any of, even from the audience, anybody knows about TUG by developed Dr. Donald Schwartz? TUG, you don't know?
No, sir.
Okay, you may please go through there are lots of paper on TUG, TUG, therapeutic ultrasound for glaucoma. And I have no financial interest, but I have converted one dental ultrasound scaler to use as a TUG machine. And in lots of WhatsApp group, it has been viral also. So you may find it out from. And by doing that ultrasound therapy on the eye, glaucomatous eye, or hypertension in eye, for 2 years, patients remain IOP much lower, 20 to 50% lower than its baseline pressure. So the one question of affordability and compliance can be tackled with that machine also.
Now,
Are these two lights are needed actually? Two big focus light? Any audio visual or light specialist?
I think they need for photography or something.
For
video
photography?
making.
Okay.
Na? Now next speaker, Dr. Soumya. Please come. Then we will have the question answer session.
It's Soumya. You have presented and then.
Yes, ma'am. Okay, after this.
Soumya, please. Yeah, thank you. Thank you, AIOS, for this opportunity. Let me go through the decoding RNFL OCT in glaucoma, a practical version. There is no financial interest. As you all know, it's a very vast topic. I will try to reduce it in 7 minutes. What is OCT? OCT is a non-contact, non-invasive method for examining the optic nerve and the retina and providing ultra-high resolution cross-sectional and three-dimensional images. It is based on the principle of interferometry. So, the first and foremost thing that is very important is the normative data for OCT. It is generated by evaluation of the normal individuals of different ages and different OCT machines. So, these cannot be used interchangeably. So, the most important thing that we have to look in a OCT paper, that is parameters relevant to the glaucomatous abnormalities. It can be classified into three. First one is the retinal nerve fiber analysis, that is the RNFL analysis. In the OCT, there are two strategies, that is mainly the RNFL thickness map and the RNFL deviation map. So, RNFL loss, whether it's inferior or superior, causes a wedge-shaped RNFL defect with associated localized notch in the NRR. So, this is a picture of RNFL thickness map, that is, they are pseudo colors. Blue is thin. You have to remember this. That is, RNFL thickness map, the blue is thin, while red and white are thick in the normal eyes. So comes the next one, RNFL deviation map. What is it? It is red is thinning. Red is thinning in the RNFL deviation map. So this uses an interface retinal images highlighting the cup, disc edges and calculation circles upon the significant deviation from the normal is superimposed in red. So the next one is RNFL calculation circles. That is 4 quadrants: temporal, superior, nasal, inferior and temporal plots. So this is it. Normally there will be a double hump pattern. You can see the superior one and also inferior one, there is a hump-like position. So you have a pointer. So that there are 2 humps. That is the normal double hump pattern in the normal eyes with a peak in supero and inferotemporal quadrants. Coming to the next one is macular ganglion cell complex. The 50% of the RGCs are in the macula. So, our GCC loss and macular thinning in arcuate shape with corresponding NRR loss is diagnostic. This is the picture of the macula. So, in different machines, it has different methods. In a serous segment, GCC includes IPL and the ganglion cell bodies, but excludes the NFL. While in the OptiHue, the NFL2, whereas the spectralis, it measures total macular thickness. So, coming to the optic nerve head analysis, Brooks membrane is considered as the boundary for this. These are the different machines having different methods of calculation. So, this is a practical version. So, I will be dealing with how to read an RNFL OCT in a report. So, it will contain what all the things that it will contain. You will get a report like this. So, what are the important things that you have to see in this? The first one is the patient information. It consists of the age, sex, examination date, time, birth, patient's registration number. It needs to be fed into the machine once and it can be recalled for the subsequent scans. So, the first and foremost important thing is patient information. Then second one is the quality of the image. What is the quality of the image? For each machine, it is specific for each machine. That is, for Cirrus, it is more than 6. For Spectralis, it is more than 15. And RTView, it is more than 45. You have to next check the quality of the image. Then what is the third one? 3 tomographic scanning images. That is horizontal, vertical. It is marked on the DMO. And And I told you earlier what is the 4th and 5th NFL thickness map and also the deviation map. And the table of parameters that is compared with the normative database in the cirrus. Then I have told you about the curves, that is temporal, superior, nasal, inferior and the temporal color coding pattern, then double hump sign. That is RNFL quadrant and Glaucoma's average. So in this picture you can see the RNFL thickness map, blue is normal, while the RNFL deviation map, red is abnormal. And these are the horizontal. The BMO is connected as the margin, and the external vertical tomography and circular tomography all should be normal. And then neuroretinal rim thickness, RNFL thickness, you can see the hump and the RNFL quadrants and the clockers. And this is the column. Okay. The GCC analysis also defines it like that, the same method. The thickness map blue and the deviation map is red. This is the picture of the spectralis optic nerve head analysis. The cirrus has a software called a glaucoma progression analysis where 2 baseline scans are later compared to the follow-up scans. So the name, age, everything has to be important. So once it's fed and the repeated scans, you can get from the cirrus machine like that. So a parametric table is also provided in the analysis and a color coded to deposit change over time. And the colors indicative of the childhood of progression with their significance being mentioned in the lower right part. So this is the progression analysis map. So there are factors leading to the misinterpretation of the OCT. What are those factors? You may have heard about red-green diseases. The green is normal, red is abnormal in the normal eyes. What is red disease? It's a false positive in otherwise normal eyes. And a green disease is a software couldn't identify the disease itself. So people with tilted disc, high refractive errors are more prone for this. What is the floor effect? RNFL thickness that is more than 30 micrometer is dictated by OCT segmentation. If RNFL thickness is less than 30, cannot be dictated in advanced glaucoma. So GCC or visual field is more useful in these cases. And the poor quality of the scans, the segmentation errors, that is improper placement of the segments. So what are the artifacts? There are different types of artifacts that can occur in the OCT scanning. That is maybe patient dependent as well as device dependent. What are the patient dependent? Media opacities, pupillary diameter, or maybe operator dependent, that is centration, signaling strength acquired, device dependent, acquisition speed, database, etc. So OCT studies have shown that dry eye and cataract can quality of index decrease in RNFL thickness. Patient should be encouraged to continue physiological blinking during the alignment and blink just before the scan. Floaters and the opacities also interfere. What are the incorporation of OCT into the practice? It is important to dilate the pupil for consistent image quality. You can use the same machine always, okay? So let's go through one case. A 60-year-old male with IOP 32 and 36 millimeter of mercury, cup disc ratio of 0.9 both eyes, 612 vision in both eyes. So this, let's see, this is the OCT. So what do you see in those OCT? You can see RNFL deviation match shows thinning, superior and inferior. Okay? And the NRR in the temporal, superior, nasal, inferior, in the right eye, red, and the left eye is normal. So what is it? It is a POAG advanced, maybe macular GCC, better to be done in this case. Now coming to the case 2, a 60-year-old male, a POAG diagnosed, came for a second opinion. But first of all, what should we see? The signal strength. It is only 5/10. So it came as this. The patient came with this report. So I have to repeat an OCT. Let's see the OCT. Everything is normal. In this, you can see the tomograph. It's abnormally placed. So it can't be taken into consideration. So we have to repeat it. Now everything is normal. So we can calculate from this one. Okay? Now comes a 14-year-old child with operated congenital glaucoma at 1 month. Now IOP is 12 and 14 and vision is 660. What should we do? The OCT reports comes like this. It is absolute map values for the normal data are not available. So we have to absolute values may be followed up over time. Thank you.
Thank you, Dr. Soumya, for the presentation. One question I would like to ask you, is there any correlation between myopia and RNFL thickness which is determined by stratus domain OCT?
Pardon, sir?
RNFL thickness which is seen on stratus domain OCT and in myopic patients, is there any correlation?
Yeah, myopic patient, it can't be taken. So the myopic correction should be done.
Yeah.
And it may be abnormal seen. I had told in the video.
Yeah, that is very important
Yeah.
actually. Because if the patient is myopic, there can be RNFL thickness reduced,
Yeah.
which will be shown. So we have to take that into consideration. Before yeah, very nice person.
Thank you.
Now I would like to call upon Dr. Saroj Gupta ma'am for the presentation.
So very good afternoon to all, and I want to thank Scientific Committee for giving me this opportunity. So I'll be speaking on compliance, adherence, and persistent, what they give challenges in the glaucoma therapy. So is adherence an issue for glaucoma management? Yes, we know that glaucoma is a leading cause of irreversible blindness, and the first line of management in POAG is the ocular hypotensive drops, and patient has to put these drops for a long time throughout their life. And since it is an asymptomatic disease, so patients don't understand, they don't get any visual benefit, and therefore they don't understand why to put these drops, and therefore adherence, persistence, and compliance is a major challenge in treating glaucoma in these patients. And we know that non-adherence can lead to progression of the field loss, and patient can lose vision if they don't understand about the disease. And there are studies which show that 50% of patients are found to be non-adherent to their medication over 75% of the times. So it's a big challenge. So let us understand what do you mean by compliance, adherence, and persistence. So compliance means the extent of patient's behavior corresponds with the physician's recommendations. So patient says, yes, I am putting medications, I am using, so patient is cooperative. But adherence means active participation from the patient, means patient says, yes, I am taking medication exactly as prescribed and following the regime. So persistence is the most important challenge. And adherence is the most important, and persistence means the length of time or duration for which patient continues to follow that regime. So patient says, I am taking medication as prescribed with correct dosage, correct eye, correct time, and for the duration it has been prescribed. So these are the things which are very important in medical management of glaucoma. So what are the barriers? Why patients not adherent to the glaucoma medication? So they are classified as into 4 classes. Can be patient factors, can be medication related factors, can be provider factors, or can be situational or environmental factors which cause obstacle in following the regime. So what are the patient factors? Could be a forgetfulness. The patient, they forget to put the drop. The regime is so complicated, they forget to put the drops, when to put which drop at what time to put the drops. So they forget to put drop, or patient may be having systemic comorbidities along with glaucoma, like the patient may be diabetic, may be hypertensive, patient may have some cardiac issues. So patient has so many medications to take, so patient doesn't follow the regime, or patient doesn't understand the disease. It is very important to make the patient understand what is glaucoma and what it is a vision threatening disease. The patient should know the importance of putting the medication. So giving knowledge of glaucoma, giving chair time to the patient, explaining the patient about the disease before starting treatment is very, very important in glaucoma. On top of it, patient may have poor manual dexterity. Patient may have tremors, may not be able to put the drops, or patient has a poor eye-hand coordination. Patient may have a poor vision, not able to see which drop to put, when to put. These are all factors which are patient factors which lead to poor adherence to the glaucoma management. Then there are medication-related factors also there. The complex prescribed to the patient is so complex. There are multiple medications, more frequency. The patient has to put 1 drop at once, other is 2 times, third is 3 times a day. So patient get confused. It's so inconvenient for the patient. So regime is related factor may be there. Or these patients have side effects also because of these drops. They may have ocular side effects, they may have redness, they may have allergy to drops, or they have side effects systemic also. Drowsiness is one of the important side effects. So patient may not like to put the drop because of these factors. Economical issue is the most important. It is there's a recurrent cost of medicine involved because they have to use drops for a longer duration of time. They have to buy the medicines every time, and they have costly medicines. So cost is an important factor, and sometimes patients who are residing in remote areas, availability of drug may be a factor. Doctors prescribe a particular brand, patient may not get the particular brand, and patient may stop using the drop because availability is not there. And we have seen this in COVID times when drugs were not available and the patient missed the dosage. Then there are provider factors also. There's a poor communication between the physician and the patient because the disease has not been explained to the patient properly. The rationale of prescribing so many drugs has not been explained to the patient. So patient is not satisfied that why he should use all these drops when he's not getting any benefit from putting these drops. There are environmental factors also for poor adherence, like patient is traveling job or patient is away from home, not able to carry the medication, there's change in his routine. There's a lack of caregivers are not there who can help him in putting the drops, or there's nobody to escort the patient for the follow-up to the hospital. That may lead to discontinuation of the treatment, or there's a lack of support from the family. There's nobody to who understands about the disease and provides the medication to the patient. So there are so many obstacles are there in the medication. So there's a glaucoma adherence personal study which identified following factors. There are many studies which have tried to find out what are the most important factors for poor adherence, and they found that cost is the most important factor. Patient not able to buy so costly medicines for such a long period, and forgetfulness in 32%, fear and denial in 16%, lack of understanding about glaucoma in 16%, and complexity of the treatment was in 15% of patient. So how do we find out, how do we assess the adherence, whether the patient is adherent or not adherent? Like we have prescribed the medication, patients come for follow-up, and we don't know whether the patient is putting the drops or not putting the drops. So how do we evaluate the adherence to the medication? So there are direct methods and there are indirect methods of assessment. Direct method is that we observe the patient taking medication. So which is the most accurate method. So patients observe that patients putting the right time and right drop, or measuring the concentration of the drug, metabolite in the blood and urine, which is very expensive, and this direct method is not feasible, it is cumbersome. So there are indirect methods also for assessing the adherence to the medication. Either can be patient self-reporting, so patient reports, said that I am putting medication, and we can ask certain questions about the awareness of the disease, understanding of the disease, about the medication, which drop, at what time patient is putting. That is one method. Second is we look for the refill rates. How many drugs patient has used in the period, or measuring the amount of medication in the bottle. We see whether the bottle is full or it is empty, or we can count number of bottles patient used at the end of the month. These are all indirect methods. There are studies on utilizing electronic medication monitors also, like the Treviton dosing ad is there, in which to the bottle is a device attached to the bottle. Every time when patient presses and puts the drop, the device will record the time as well as the number of drops. Or patient can be asked to maintain a medication diary when the bottle was purchased and how many bottle has been purchased, when was the patient was putting the drops. These are indirect methods, but they are not very accurate, and no technique is without flaws. What we can do is, how do we find adherence is that we measure IOP and see whether what target pressure we have set, that the IOP is controlled in that range only, and whether glaucoma is progressing or it is stabilized. That is how we can assess the adherence to the glaucoma medication. But there is no consensus on which is the best method for measuring the adherence to medication. Then another syndrome is white coat compliance syndrome. This is something very interesting. Some of the patient, what they do, they will start putting drops 1 week before they come for follow-up, and then they'll stop after that. So when a patient comes, you find that the IOP is normal within the range, but the patient is progressing. So it is very important to find out this, whether the patient is doing this, and this may lead to, we may add medication, we may change the medication, find that the patient is progressing, though the IOP is controlled. So we may think that this medication we are giving is not adequate, and we may add on more drops. And this will further complicate the regime, and this will lead to poor adherence. So we should be aware of this syndrome also. So ultimately, how do we address this problem of non-adherence? The most important thing is educate the patient about the disease, because many times patients don't know which disease they are suffering. They know that drops have been prescribed, but they don't know about the glaucoma. So teach the patient about glaucoma, tell about what is the disease, what are the side effects, what are the importance of putting the drop, and what will happen if the patient doesn't remain adherent. We can use educational videos, we can give some informative material to the patient to read, or personalized counseling can be done in the OPD. We can have counselors who can teach the patient how to put the drops, can tell about the disease, and can tell about the importance of adherence and compliance. Even educating family is also important, because they have to support the patient for this medication. And another thing is to simplify the regime, whatever we are prescribing. Give minimum number of bottles and minimum number of drops. Like we can choose a combination of the drops, and so that will help in improving adherence. We can set alarms also in the in the clocks or in the watches also, we can put some reminders so that the patient can put the drops. What else we can do is, there are certain other therapeutic options we can be opted, like we can do SLT. SLT will help in reducing the number of drops. So if the patient is using 4 drops or 5 drops, we can do SLT also in POG patients. That will help in reducing the number of drops. Or now MIGs are also very safe. So that can also be then either the stands or the KDB can be done. So this will also help in reducing number of drops, thus simplifying the treatment regime. That will improve the adherence to the patient. And now the implantable devices are also available, slow release, which will also help in reducing the number of drops. So these are the few which can be added to. So to conclude, adherence to glaucoma medication is still a challenge because patients to put the drops for a longer period of time without any visual benefit. And so patient education is the key. We have to educate the patient about the disease. They know why they have to put the drop. And we have to use a simplified treatment regime with minimal side effects. And we can add these regimes so as to reduce the number of drops, like SLT or mix can be added. Thank you so much.
Thank you, Dr. Saroj Gupta ma'am, for the wonderful presentation. Sir, any question? Ma'am, I would like to ask you, if the patient is on 3 drugs and patient is getting complaints of redness, congestion in the eyes, so should we continue with the medications or should go for surgery?
So we have to find out first which is the drug which is causing allergy to the drop.
Right.
And we can always change the molecule. And if we think we have to add another drug, then what we can advise the surgery also, either I said the mix or SLT, or we can even advise a filtering surgery also. Patient has a lot many side effects and IOP is not controlled. Or we can change the molecule also.
Yeah, you are right.
That is really done.
Okay.
Ma'am, have you heard about TUG? I
Yes,
asked the same
I
question.
read about this, sir. This is
Have you ever came
Sir,
across?
I read about it. The
You,
ultrasound you said.
can you please use your mic?
Sir, I read about this therapy which you are referring to.
Yeah.
The ultrasound.
Actually, yeah, one more thing I want to add, it will cost you just 7,000 rupees.
Yes.
The tug machine which I converted from the dental scaler machine, it will cost you just 7,000 rupees. And in my study, I'm not a professor, I'm not attached with any college or anything there. But in my private practice, I have observed 20 to 50% reduction of the IOP from the baseline. So adherence may become indirectly very much, and I treat my patient free of cost. It just costs me nothing. It's just 5 minutes treatment. There are some videos of my own on your YouTube, and you may go through the tug.
Is it available, sir, here in the?
It is nothing to like to available. You can modify this dental scaler machine, which is 6 to 7,000 rupees cost. All these machines works on 40 kilohertz ultrasound therapy. What Dr. Donald Schwartz observed, he observed that while doing phaco, there is reduction of the intraocular pressure. And what he suggested that phaco versus SICS, if the patient goes under SICS, there is no reduction of IOP or very minimal reduction of IOP with compared to the same patient if undergoes phacoemulsification. So the focal ultrasound energy cleans up the trabecular meshwork, and there is lots of another cytokinin effect also that reduces the intraocular pressure. So what he did, he made a ultrasound probe of 40 kilohertz, and he developed a machine. So from limbus, just below the limbus, he applied that ultrasound probe to this means guinea pigs and all these experiments, and he found that 20 to 50% reduction of the IOP was there. There are lots of papers also on PubMed and everywhere. So he designed that machine. So in 2014, I went to USA and I personally met Dr. Donald, but that machine was not possible to bring to India because of some other restrictions. So I thought and I worked on it, and I found that this dental ultrascalar machine, this comes with 40 kilohertz ultrasound piezoelectric crystals. One thing. Second thing, that machines, this dental scalar machine works at 30 to 40 watt power. In human, for any therapeutic ultrasound, we need just 2 watt of power. More than 2 watt is much more detrimental and necrotizing. So what I did, just change the power supply of original machine from 30, 28 or 30, exactly I forgot, but it is there on my YouTube video. So I just 12 watt, 1 ampere power supply, and dental ultrasound, the ultrascaler comes with pointed tip, and I just de-sharpened it. I made it round so it doesn't hurt to the eye. And in my personal, and we 3 people have worked on it, myself and Dr. Kakadia, if anybody knows him, and Dr. R.C. Shah from Bombay. We 3 people worked on it. We found that there is a very good reduction of IOP. Even lots of painful blind eye people benefited like anything. So they were on the drops in blind eye, and they were not happy. And this is just you being a glaucoma specialist. I just want you to do some study and highlight it.
Yes, so it will be good if it is available in the market. So
you just type dental piezo 2 piezo 2 ultrasound dental scaler. It's 6,000 to 7,000 rupees cost. You just change the power supply from its original to 12V 1 ampere power supply. And you just round up that the point. There are 5 tips available with dental ultrasound machine. Out of any tip, you just make it round, polish, and your ophthalmic ultrasound tug machine is ready. It will cost you just 7,000 rupees, 7,000 rupees. And you being in teaching institute or somewhere, you can do more study on this thing.
So there are papers, I have gone through those papers.
There are lots of papers.
There are lots of papers.
There are lots of paper, and people are benefited.
Yes.
And practical, in my opinion, yes, they are getting
So
benefit.
it will help in reducing the eye drops.
And
Compliance will
it-
definitely improve. So.
It reduces the eye drops, and suppose the patient is having 25 to 30 IOP, and if his IOP comes down to below 20, and if he doesn't put any drops for maybe 2 years, so he is off the drop for 2 years. My longest follow-up is 18 to 20 months. Yes. And almost most of the patients, they don't need drops if they are between 25 and 30. If they are 50, something like that, glaucomatous blind eye, then their pressure comes down to 25 to 30, and with 1 drop, they are happy. And band-shaped keratopathy, and we get lots of other problems of high IOP.
Thank you so
So
much,
this
so much
is
for
my
your information.
observation. I thought I should share with you,
Yes,
and no financial interest.
Sir, we have to apply it on below the limbus.
Yes,
Ultrasound.
1 millimeter away from the limbus.
Okay.
And
For how much time?
Dr. Donald Schwartz applies it for 1 minute, 5 spot. So for example, lower half,
Okay.
1, 2, 3, 4 and 5 in lower half,
Lower.
or in upper half.
Okay.
Okay. And he repeats the same treatment, 1 minute each spot. He just putting the paracaine drops, that's enough. You don't need any injectable.
Like we do cyclocryo like that only.
It is exactly like cyclocryo, but you are
Okay.
not
Applying the
cryoing
cryo
or
probe?
destroying anything. You are
Okay.
just cleaning it. Some people named it traboclean, means it cleans the trabecular meshwork. And we know the theory of ultrasound. It is a very huge, there are lots of chapters on ultrasound. I read all these things.
It acts on ciliary body to reduce the aqueous humor. Like, do you micropulse cyclophotogalactin we are using?
It is not micropulse. You need to do it continuously, but you need to put not more than 2 watt power. 2 watt is the borderline, because any therapy on human body, 2 watt is upper line. We are taking ultrasound therapy for our achy muscles and all these things. All the machine works on 2 watt power only. If they increase the power more than 2, then it is damaging and necrotizing to the tissues.
Right.
So this is borderline.
Yes,
Thank
sir.
you. Thank you so
sir.
much. Thank
There
you,
was
sir.
very small change which I could make.
Yeah, it is very innovative thing. So let us study this thing, and in the hope in next conference somebody will present a paper on this.
Thank you, sir.
So, thank you ma'am, thank you very much for the presentation. Now coming to the question and answer sessions, anybody who wants from the audience who wants to ask a question, please come in front and ask the question in the mic. We are still having 10 minutes for this
All
session to complete.
faculties are over here, those who have
Any
delivered
other
the talks.
faculty remaining? Everybody has completed with their presentation? Okay. Yeah, please tell me. Medications. Yeah. SLT would be one of the answer. Selective laser trabeculoplasty can be done. It I have seen in many patients the medicines. If the patient was on 3 medications, he has come to one medication, and those who were on 1 or 2 medications, they were without medications for around 18 months to 24 months. So, but again, it requires still more precision to be done. And if the patient is not affording, then we can go for one-time surgery. Trabeculectomy can be done. So that, sir,
Should I put my own thoughts? We have observed that physiological IOP increasing factors like drinking a lot of water, and doing inverse yoga, what we call Shirsasana, and trumpet player, all these things. So what does all this thing does? It increases the blood volume. It increases the sympathetic tone of the body. So this is absolutely offbeat talk I'm doing in front of you. But if we do other way around, if we do parasympathetic overtone of the body, can we reduce our IOP? Can we reduce our hypertension? Can we reduce any other lots of other anxiety, all these things? Because I have done Vipassana sadhana. I'm very much sorry to, because even though this is not under this jurisdiction, but once my IOP used to be between 17 and 18. My CCT remains 55, 555 and 560. So 17, 16, since very long, my IOP was there. So once I completed Vipassana sadhana, and my IOP came down to 12 and 13. So my observation, so we are under continuous sympathetic overtone, which in nature has given us to as a fight or flight mode, and to tackle any emergency. Ideally, we should be under parasympathetic tone, and parasympathetic tone reduces all the intra-body pressure, so we should also, this all glaucoma experts should start doing study, whether keeping our body under parasympathetic tone can reduce physiological intraocular pressure and can reduce glaucoma or ocular hypertension. Yeah. And it is in positive, so it is possible. So why only the glaucoma patients should follow the meditation? Why we so-called normal people also should not do meditation and all these things? Because
definitely we
lots
should
of
do.
people are taking anti-anxiety, anti-hypertensive, beta blocker. Even myself was taking beta blocker, and I had to stop my beta blocker, anti-anxiety, anti-hypertension, all these medications too.
Right, sir. Very nice point. So we should go for that also. We should actually ask the patient to follow all these things, physiological things, which can help to reduce the IOP. So that could also reduce the burden of the cost. Yeah.
Anyone would like to ask?
Any other question from anybody else?
Still, we have 6 minutes to hand over this hall to the next session. 5 minutes. So any absurd, question or any absurd talk, even welcomed over here, because it is not just learning in one way. We learn by so many things. So shall we conclude the session?
Sir,
Please.
question is there. Please come to the mic, sir. Please.
Sir, I didn't get the question. Can anybody simplify the question, sir? Blood pressure, yeah. 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 Yeah, oral beta blocker and oral antihypertensive medicine does help lowering the IOP, yeah. Lowering the intraocular pressure also. That is the observation of all, I think, glaucoma experts. So that is only the sympathetic overtone. That is what we conclude in other way around. Okay. Okay. So shall we conclude the session? Shall we?
Anybody else who want to ask last question? Nothing. Dr. Harbansh Lal sir is there, master of phacosurgery. One question for you, sir, please. Sir, we have discussed right now that it was seen that phacosurgery reduces intraocular pressure. So what is your observation about that, as you are the master of phacosurgery, sir? Sir. Okay. Okay. Okay, sir. Thank you, sir. Thank you very much.
Any glaucoma experts want to comment on this thing? Wants to?
Right, sir. Okay. Okay. Yeah. Cleaning of the trabecular meshwork is done. Okay.
Cytokine,
Okay.
yeah.
Okay. Thank you.
By doing tug, if you do tug on one eye, other eye IOP also gets reduced.
Okay.
This is my personal observation.
That's good.
Cytokinin A and cytokinin C effect, something like that.
Okay. So definitely we should
Yeah,
all
we
study
should
about
try
that.
that because
Yeah.
it is non-invasive and the cost is just, you know, just peanut.
7,000 is not that much.
It's not
yeah.
that.
Yeah, yeah, yeah. Yes, sir.
So let us hand over the hall to our respected
Yeah, so
teachers.
before handing over the hall, I would request all the speakers to please come on the dais for a group photo, and then we'll